So, good morning, one and all present over here. So, I, Samila Mishra, on the behalf of the SciComm Synapse, would like to invite you all on this auspicious event, and I would like to thank Dr. Krishna ma'am for joining us and giving us time for this event. So, moving on further, I would like to introduce our esteemed speaker, Dr. Dr. Krishna. So, just a second. So, on today's episode of our Science Chat, we are excited to welcome Dr. Krishna Sireesha Sundaragiri, a distinguished professor and a former head of the Department of Oral Pathology at RUHS College of Dental Sciences, Jaipur. With over 13 years of experience, Dr. Sireesha has an impressive background in oral pathology, specializing in the early diagnosis of oral potentiality malignant disorders and oral squamous cell carcinoma. And her research explores the application of artificial intelligence and salivary diagnostics in the field, with a particular interest in oral lichen planus, a disease she believes plays a critical role in oral cancer development. Dr. Sirisha's contribution to the field have been recognized with numerous awards, including the 2023 Proficiency and Appreciation Certificate by RUHS and the Best Scientific Paper Presentation at the 29th National Conference of Oral and Maxillofacial Pathology in 2022. She is also an active guest speaker, having delivered on lectures on topics such as oral cancer, red and white lesions, and molecular profiling in odontogenic tumors. We look forward to learning more about her insights and contributions to oral pathology today. Welcome. Thank you, ma'am, for coming us and we will be providing us new insights in today's topic. So, very welcome, ma'am.
Thank you for this wonderful introduction.
Ah, thank you, ma'am. Yeah. So I'm moving. So can we move further on the event? You
Yes,
allow?
yes.
Yeah. So ma'am, moving on the very first question, oral pathology is a very kind of a new topic for me. Being a molecular biologist, I haven't discovered. So ma'am, what inspired you to pursue a career in oral pathology, and how did you choose this field over other specialization in dentistry?
So basically, I am a dentist. So my first primary graduation is bachelor's in dental surgery, and then I moved on to do a specialization that is my MDS. This is Masters in Oral Pathology. I think from 12th, I always wanted to look into the microscope. That was my passion. I never wanted oral pathology. But dentistry happened because I didn't get MBBS. Simple as it is. BDS dentistry was never the first choice. But once you get into dentistry, it is like I think all the dentists, whoever is listening, they'll all agree that dentist is part artist, he's part physicist, he's part chemical engineering also involved in that. Not only just being a doctor. So once this stream catched on, then I cleared my All India postgraduate entrance exam. So there I get a government seat in oral pathology, and that's how the journey in oral pathology starts. And my UG college had a huge role to play because there were excellent teachers there in my subject, and I'm in touch with them on regular basis. So they're all motivating to take up this subject, a subject which I think all of us agree that is not still not recognized in India, but maybe as you have insurance and people acquiring more and more knowledge will start realizing that oral pathology will play a major role in diagnosis and then clearing your insurance bills also.
So, ma'am, apart from this, so ma'am, oral pathology is a kind of very specialized and challenging field. So ma'am, what were some of the biggest challenges you faced and how did you overcome that?
uh, Actually, if somebody who's training in pathology will tell you that pathology is basically patterns, and we are like small Sherlock Holmes in our own microscopes with our own scopes to get into that. It's a different world under the microscope. Like one of my teachers said that outside world is different, the inside world is totally different, and anybody who looks into the microscope will tell you that it is much larger, unexplored. So the challenge is to recognize those patterns, learn them, and every case, actually, dentistry or be it being a doctor also, every case is different. So applying that knowledge to your case is the challenge in oral pathology. And not every case could be the ideal case scenario. So then there's lots of brainstorming that is involved in this. And I would like to point out here that in pathology we are actually the connect between the clinician and the patient. So we are the ones telling the patient, yeah, you have a problem. So it's a challenge in itself to convey to the patient that yes, you have a problem which needs to be treated. So yes, those there are lots of challenges uh, at the level of diagnosis. There's lots of challenges at conveying the patient also. So we need to be good convincers also to the patient to undergo that particular treatment. And believe me, it is not easy to tell somebody that you have cancer, and the stigma associated with these terms. And you will see in my presentation also that there will be this huge number of cancer cases that now we are coming across, and how we will have to say that yes, we are there and raise our hand saying that as dentists, as oral pathologists, we are there to help you, and help you treat it as well as prevent it also. So there's a lot of role that we have to play. So those are the challenges that we come across every day. With every patient is something different. He comes with his own different psyche. And then how important is your connections with your surgeon, how good they are with your radiologist. So pathology does just not involve just seeing to the microscope and give an answer. It's like how we interact with our colleagues. It all matters.
Yes, ma'am. So what I feel about pathology that we need to keep ourselves updated because new microbes come up every day and today. So, ma'am,
Yes.
how do you keep yourself updated with the latest development in your field? And do you have a particular routine or practice that helps you stay ahead?
uh, you need to be upgraded at this. I think the only thing that is constant is change. And if you get like, I think my undergraduate students, the interns, they have a major role to play. The new generation which comes, they have come with a lot of ideas. So if you are not upgraded to their level of requirement, then you are old already. So it may not be if we am not opening my journals, if I'm not opening the latest publications, we have already moved back by 5 years. So the constant number, and I think all of us would agree that COVID has been a life changing moment for most of us. We did not experience COVID per se, but during COVID we did networking. We used our social media platforms to network with all over people all over the world. It got us much more together. So if we follow each other, and we again, as I think your entire synapse, the community's perception is to work together as a team. So one person, like if we give feedback, positive feedback to somebody, somebody else will be encouraging you as well. So those connections, then I think social media has played a major role to keep us upgraded. So people are putting up their data, or they're putting up their new publications online, so you are going and seeing those. And usage of certain I think I would still recommend using researchgate. I mean, we follow so many big authors that are there in our field. That has been a very good source for upgrading the knowledge that we are possessing. And I think most of this publication media, they also want us to upgrade, follow their new steps also. And then and how to work and how to upgrade yourself also. We have so many online platforms also these days. And I said interacting with students is the best way to learn. I still feel that.
Yeah, yes, ma'am. So yeah, this online platform, what we are doing as well, it is really helping us a lot, as well as we are also learning a lot, because we also don't know many things about the new field like oral pathology. So ma'am, you talked about COVID.
Hmm.
Yeah, recent. So how can you link oral pathology and COVID? So while testing and all, what aspects do you think see in COVID things? Can you
Okay.
please
Yeah,
shed
yeah, I
some
can.
light?
Yeah, I did. I did. See, the first wave was a shock. Suddenly, the Prime Minister of India declares entire lockdown. So I think the first wave was more of a shock, but the second wave posed a lot of challenges for as in dentists also. So with the second wave, the first wave was like we just went for duty and came back. We had our protocol set, we had our duty hours, we had everything was fixed. But the second wave, with the second wave came the black fungus, mucormycosis, and it actually primarily affected the oral cavity and the maxilla, basically the area that we specialize in, the oral and maxillofacial area. So at that time, I would say that my husband was very, very motivational. That what are you not doing? That is your field actually. So he motivated me to go back to my books, to go back to my teacher. I went for a day to the medical college, learned what to do, how to diagnose, how to help. And I'm very glad to tell that with the help of my medicine colleagues, we came up with a procedure to diagnose this rhino maxilla. That is, rhino means nose, and maxilla, that is upper jaw, mucormycosis. So we have a patent recently, the technique that we developed to study how this whether the fungal is actually causing the problems. So we have a patent right now on that technique. So it's called as a 3-level grossing technique for mucormycosis, that was very, very common post COVID, especially post the second wave, like everybody used to call that black fungus. So we have done extensive work during that time. There was a lot of support from the institute. The surgeons were extensively dealing with it, so we were able to develop in-house facilities to diagnose it actually. So we were very, very active during the COVID period as oral pathologist in the department, in the lab, with every support from all my colleagues. So COVID taught us that with our limited resources, we still could provide the services to the patients actually.
Hmm.
And I
Yes,
said,
ma'am.
we just developed a patent over a small procedure. So that's some steps, small steps led to bigger things.
Yes, ma'am. So in COVID times, it has been seen that many people have doctors have prescribed antibiotics. Although COVID is a virus and prescribing antibiotics, I don't know why. So ma'am, due to that, some antimicrobial resistance has been seen to develop. So do AMR and oral pathology have some link?
I think they do. They do. Look, see, actually, would you believe? I would ask question everybody. In the incidence of dental diseases actually in India is very, very high. We don't never recognize it. So problem is, there is something we call as over prescription. Over the counter prescriptions are very common in India. Like nobody goes to the doctor first; they go to the medical store. They go to the chemist. They believe in the chemist. So as you said, this antibiotic resistance is basically, see, if you go to foreign country, maybe US and all, you need a proper prescription from the doctor to
Yeah,
take all these medicine. Here anybody can give you.
yeah,
And see, the thing is that even doctors have been uh, like, they are very much aware of it, but it's like, the patient wants instant relief. Nobody's
uh,
ready to wait that 5 days to take out the dose to take effect. So rampant use is there, definitely. And I don't know if you know that, but I personally feel that India we are a land of abundance. We have so much of sunlight, we have so much of moisture, we have so much of everything. So microorganisms love our country, so we have lots of them also. We are not extreme temperatures. We have ambivalent temperatures for all these to grow. So,
Yeah,
so
that's
they also mutate according to the situation. I feel they are more adapting than we are to them, actually.
yes, yes, that we can see.
That we
Yeah,
can see.
yes, ma'am. So, ma'am, moving on further, yeah, when I was going through your introduction, I found that some technical terms which I even like oral lichen planus, malignant transformation. So, ma'am, can you please shed some light moving with your slides and presentation so that even I can learn more and our audience can also learn
Sure,
more?
sure. So I'll do share.
Yes, ma'am.
Yeah, is it visible?
Yeah, yes, ma'am. It's visible.
Yeah. So I'm Dr. Krishna Sireesha. Uh, I'm
Can you please
professor
make
in.
it full screen
I
in
have done.
slideshow? No,
Yeah,
it's
I've done.
not coming. It's not
One
coming
second.
in slideshow mode.
I'll just do it again. Just give me a second. Is it visible now?
No, can you please share your entire screen? Then it will be
Okay,
visible.
I'll do that. I'll do that.
Instead of sharing a particular screen, share your entire screen. Then it will be visible.
Uh, is it visible now?
Now it's visible. Now it's
Yeah.
visible.
Yeah, I'm Dr. Krishna Sireesha. So I'm professor in the Department of Oral Pathology in RHS College of Dental Sciences, Jaipur. I'm here to welcome you to my world of pinks and blues, actually. So, as I said, we are dwelling deep or digging deep into our smiles, exploring the past, present, and future of oral pathology. Uh, my world is basically into the microscope. We see a lot of tissue, and oral pathology has an extension of oral microbiology also. So we do know a lot of about oral microbiomes and microbes that have a role in dental caries or periodontal disease, actually. um, those who are listening to me, there's a small question for you. Can you name the world's oldest disease? That is the question. If we keep our thinking caps on, it is actually dental caries, which is the oldest disease that is known to mankind. Fortunately for the dentist, unfortunately, it is the most commonest and widespread disease in the entire globe that affects the human beings. It is not diabetes, it is nothing else, but it is dental caries, or in simple in Hindi, if you say, it is like daat mein keeda lagna is the most commonest disease in the entire world. So here, dentist per se, and then eventually all the diseases that cause because or the sequelae of dental caries is where the oral pathologist plays a role there. So as I said, tooth decay is the world's oldest and most widespread disease. Now, when we come back to the question, when do we see a dentist actually? I think all of us will agree that we all have this something called as the white coat tension, hypertension, that when we have to go to the doctor, we always have a step back. So when you have a white or red lesion or ulcers which on your oral cavity, it could be tongue, your gums, or lining of the mouth, that don't go away. So that is primarily when an oral pathologist has a role, or an oral diagnostician who has a role to play. Yes, dentist, I would still prefer that you, as a regular basis, every 6 months you have to visit. But when there are some challenging cases where I think all of us would know what are stress ulcers, especially when we sit down for our exams, we all have these ulcers that are sprouting up in our mouth, and then we need to get rid of them, and they're very, very irritating. So, coming back, mouth is the mirror of the body. It actually is really, really valid. Healthy mouth tells us the story of a healthy body. 90% of the medical illnesses have oral symptoms. So we may be the first people to diagnose that underlying systematic or the health problem. The periodontal disease of the gums. See, with age, with every age group, there's certain particular dental diseases that come up. But if we have a good oral hygiene practice, we regularly visit the dentist, most of these are preventable. As again I said, systematic like diseases that affect the general body, that is diabetes or heart diseases, have implications in oral cavity. Certain diseases are linked to the generation of those diseases. So taking good care of teeth and gums actually may help us to live longer. Now, what could cause poor dental health causes? So, what problems could poor dental health cause? It could lead to primarily tooth loss. It could lead to bad breath, and it could lead to gum disease and tooth decay in person. But it also leads to other disorders, such as it could flare up your diabetic condition. It could lead to the mouth cancers, throat cancers. It could lead to heart disease, certain bacterial infections of the oral cavity. Those species have been found in infected valves of the heart. Uh, Lung conditions also have been implicated, where certain diseases carry over to the lung. Now, one primary disease which we call as the periodontal disease, or the disease of the gums and the where teeth become mobile. There is a relationship between the cardiovascular, that is your lungs, and the heart disease, because there's a common link between all these diseases, that is the inflammation. And the particular marker that has been now implicated in the development of this disease is the IL-6, that is the interleukin 6. If somebody knows what is interleukin 6, it is an inflammatory marker. So the presence of periodontal disease can be associated with heart attacks, kidney disease, diabetes. Also, a lot of studies have been done where preterm births of small children have been linked to the presence of periodontal disease in the mother. Now, as you wanted to know about what is oral cancer, before we go to oral cancer, we have something called as the pre-cancer. Now, the word that we prefer using is the potentially malignant disorders. Now, potentially malignant disorders include those set of diseases which have a potential to develop into oral cancer. And the area of my interest is something called as oral lichen planus. See, now I all keep explaining when I talk to my students or anybody that lichen planus comes from the word lichen. Lichen is basically a moss that is spread on stones. So similar to that type of growth, when you see lesions on your skin or the oral cavity, it is called as lichen planus. And one of the most commonest cause which we all see in this lichen planus development is stress. Or most of the time, people don't know why you develop this disease. So there's so many areas of research related to this pre-cancer portion of the oral pathologies or the diseases that develop in the oral cavity. Now, coming to the later part of the pre-cancer part, that is the oral cancer statistics. What I personally feel is that yes, oral cancer is curable, but I feel oral cancer is preventable. Why it is preventable is where the dentist and the pathologist, the diagnostician, will play a major role. But to see in general why I'm stressing so much on oral cancer, the incidence in 2022, that in India, about 14.7% men and 5% women per 1 lakh women were suffering from oral cancer. And oral cancer is the most common cancer in men and the third most common in women. And 95% of these oral cancers were related to tobacco use. Now, tobacco use is nothing compulsion to it. It is just an addiction that if we could control, or people should be made aware about it. See, the government is doing a lot of regulations, lots of act, but we as the end users or the end people have to control our urge. So there, doctors also will play a role. Psychological treatments will play a role. Tobacco substitutes will play a role. The problem with tobacco use is that see, the market also is, or the developer of all these products also, they are also very equally intelligent. So they now, if there's a stigma over BD or cigarette use, now we have vaping, we have vapes and all that. So they are found more commonly used by younger generation, which find these as cool or something like that. So these are all things which we can avoid using, so that we don't get to the stage of cancer. The treatment costs with advancing stage, they are more extensive surgeries have to be done, and survival rate, definitely as you go with the stage, as advanced is the stage, it becomes even more difficult. It is almost 5% if in the advanced stage of oral cancers. uh, what we need to realize is that we are seeing in lot of younger age populations in India developing oral cancer. So it is the second and the third generation also we see. And believe me, a lot of people in from the age of school, actually the government has a lot of regulations of not selling tobacco, developing tobacco free campuses. I mean, we have all over our campuses, we have, I think all of us have noted, where we have written we are tobacco free. But the problem is that just right adjacent or the right next gully or the corridors have these small shops or thadis, what we can say, selling gutkas, selling small pouches of tobacco, which most of the younger generation finds it cool to have. So there's lots of work that requires to be done from lot of organizations, government side, even the doctors have a larger role to play. So what are these oral cancer symptoms? Symptoms such as extensive bleeding gums or non any ulcer that is being see, the golden rule that we say that if you have an ulcer that is not healing up after 2 weeks also needs to be shown to the doctor. The doctor will be able to exactly tell you whether this is something of concern or not. Sometimes even wearing wrong uh, difficult, like dentures or prostheses that are ill fitting or wrongly made. See, the thing is that in India we have this tendency to procrastinate even our small things, like we say ki, yaar, it's okay, I'm feeling a little pain, I did not go to the doctor. But I think even a small issue also should go and show yourself, because ill-fitting dentures, difficulty in wearing dentures also may give an indication that there is some problem occurring in the gums or the lining of the oral cavity. Then swelling in the necks, swellings that are not having any known cause, if you are not having any infection, needs to be actually explored. Certain risk factors can be discussed for oral cancer, such as tobacco. We always teach as a six S's, that is the smoking, the spirits, so a combination of tobacco and alcohol. Then supari, the S stands for supari, that is betel nut or betel quid chewing. Also a personal history of head and neck cancer, that means if you have a familial history, somebody in your family suffered, or you had a previous history, that also indicates as a risk factor. Nutritional deficiencies. uh, I think 90% of the females in India are young females in India are anemic. Pernicious anemia or aplastic anemia patients have to be very careful. Even iron deficiency anemia needs to be treated. Sepsis or oral infections also are a risk factor for development of oral cancer, especially the association of human papilloma virus. Certain species have been involved with the development of oropharyngeal cancers. That means there is an association of certain viruses with oral cancer. Definitely radiation exposure. If, like for example, the Holocaust survivors, they were exposed to more type of cancers. If you had previous radiation therapy, you could develop a secondary cancer, definitely. And the last risk factor is chronic irritation. Now chronic irritation could be from your denture also, that previous denture that you were wearing, or could be a small metallic clasp that was used for some other thing that could lead to irritation and eventually development of cancer. All these are risk factors, and believe me, genetics also plays a role. uh, in oral cavity, sunlight may not have a huge role, but yes, melanoma and other cancers that occur in the on the face, yes, sunlight also has a role. The UV light in sunlight has a role to play in the development of that cancer. Now, when we come to this is a graphical abstract of how oral pathology or dentists have a role to play. There, the term comes as oral potentially malignant disorders. These are the terms that the World Health Organization has advised us to use for the precancerous lesions and the conditions. That means they have certain lists saying that these, if you're suffering from them, you have a more tendency to develop cancer, such as oral leukoplakia. Uh, to very simply explain, leukoplakia means, leuko word means white and plakia means a plaque or a shift. So anything which appears white in the oral cavity needs to be questioned, needs to be where the doctor has to be implicated. Similar word is oral erythroplakia. The word erythro there refers to redness. So these two are two primary conditions where tobacco has implication in their development, and they have a potential to turn into malignancy. See, the malignant potential refers to that how much percentage chance of that lesion existing shifts to oral cancer. The oral erythroplakia has about 8% chance, whereas leukoplakia, most of the time, they are reversible. They can be reduced if you stop the habit. So again, as I said, most of the dental diseases or the oral cancer is preventable. So that is the basic idea that we need to understand. That most of the diseases are preventable. So there a big role of doctors, the entire patient's uh, mindset also can be modified to help him overcome this diseases. Now, what do we have is that from potentially malignant disorders which have the potential to develop, we move to oral cancer. 90% of the oral cancers are basically histopathologically diagnosed as oral squamous cell carcinomas. That is the typical diagnosis. But the problem is we don't have particular markers, or we still don't know why these disorders shift to cancer. Or there's no, like, see, for breast cancer, we have a particular marker called BRAC. If you're positive for it, you have a 90% chance of developing breast cancer. But those markers are not present in oral cancer or oral squamous cell carcinoma. So the hunt for the ideal marker is on. I think here where we as oral pathologists could be a connecting link between the clinician, the treating surgeon, and the lab, where the main search for the marker could go on. A lot of biomarkers still are being searched. Certain biomarkers like E-cadherin, P-cadherin, CD44, IL-6, they're all being still being researched, whether being the particular marker for oral cancer development. Certain imaging techniques such as the reflectance confocal microscopy have been being widely propagated at the lab level. So again, I would call upon saying that we are the connecting link from the lab to the patient, where we can do this scanning over the oral cavity and check whether directly, whether without the use of a optical microscope, you could directly check whether the mucosa is normal or not. There are certain cases such as optical coherence tomography these days, which are being used and being experimented, whether we can see a 3D images of all these development of diseases. Still, of all the new advances, oral biopsy, that is where the tissue is actually removed from the mass or the growth and checked, is still the gold standard of the entire biomarker development. So a lot of studies are being done, lot of potential is there in this site to develop. Now, coming back to again oral cancer diagnostics, the commonly available diagnostic tests used in clinical practice are something called as vital staining, that we do with a particular tissue called chemical called as toluidine blue. This toluidine blue is basically, it has this tendency to metachromically attach to tissues which have increase in the DNA content. And when applied in a particular technique, the tissues which have more DNA or DNA content will be stained. So they give an indication where the biopsy has to be conducted. and they are excellent. Vital staining is an excellent method to educate the patient that this is now the time that you stop your habit. So it plays a role in patient education. Then certain easy techniques such as oral cytology, invasive technique as oral biopsies definitely play a role in diagnosis of cancer. As I said, the optical coherence tomography, all optical imaging techniques now are coming in a big role to play in oral cancer diagnostics. The new techniques that are in development are the DNA methylation biomarkers, mRNA biomarkers, and the protein biomarkers. Like I would say proteomics. All these have major role because a particular event such as methylation of the P17 may lead to development of oral cancer, or it may be the initial marker for the development of cancer. But it is not, unfortunately, P53 is not the specific marker for oral cancer. So developing technologies where artificial intelligence will be in, integrated into the oral cancer diagnostics. A lot of work, lot of oral pathologists, lot of dentists, they are working in AI based systems. We are talking about we also are talking about ML and deep learning models, machine learning models. And eventually the whole purpose of is that we have to come to a point of care, that is where the patient is directly getting benefited, and we are able to tell in a jiffy or in seconds that yes, you have a problem or you are likely to develop the disorder. So in likely in future maybe we will be looking through here the area of interest, that is salivary biomarkers, plays a huge role. Now saliva, unfortunately, actually there's a saying that saliva doesn't have the passion of the fear of blood or the passion of tears. But saliva collection is easy, it is easy to store. Lot of companies are putting in how to collect, how to store them, how to purify it. So they're all getting eventually through saliva we are going to identify particular biomarkers which are going to help us to make microfluidic based analytic systems. These are all point of care. That means along the chair, besides the chair side techniques, we need to find all these analysis to help benefit the patient. Point of care techniques for development of periodontal disease, yes, is very much present right now. But the work on oral cancer detection is going on actually. Now again, that is how interactions of an oral pathologist will be. The oral pathologist is the connecting link between the patients. Here on the right side we have the researchers, and then we have the clinicians. And as our profession, we talk about lots of reports, we see through our microscopes, we have our lot of work. The picture credit is to Dr. Karthikeyan. So oral pathology, I believe, has a greater role in diagnosis, treatment, and research. Oral cancer, yes, we have a greater role to play. Again, as I said, the future or the time is now, where we are coming to a type of precision or a personalized medicine. Every patient is different, every patient is new. It has to be, he has or she has to be treated according to that. So the omics based molecular approaches are going to are going to have a big boom. I think all of us, whoever is listening, will agree to me over that. Lot of stem cell research is going on, lot of quantum medicine is going on, lot of point of care diagnostics is going on, along with nanotechnologies, nanoparticles, molecular imaging also is there. And believe me, traditional medicine is not going anywhere. It has to enhance itself, take the help of the newer technology to reach out to the patients. A wise person, Sir William Osler, said, as is our pathology, so is our practice. So what a pathologist thinks today, the physician does tomorrow. And without pathology, there is no medicine. This is the institute where I work. All credit to it. And thank you.
It was really a marvelous presentation. I got to know very new information, and our audience also got to know very new information. And the first question from the slides is that, you mentioned about oral graft versus host disease.
Yes.
And can you elaborate more on it little bit?
Yeah.
What are
See,
it and how it?
yeah, yeah. Yeah. See, the thing is that we in India right now have not seen so many kidney transplants or liver transplants. These diseases have been more explained in US, and so wherever patients undergo transplants, they go a lot of immunosuppression. See, you understand what is a organ transplant? A transplant is basically where a donor is giving living tissue to a person who requires it. So when the transplant is given to this one organ specifically, he is put under a lot of immunosuppression. That means the body will not react to the tissue that has been given to that person. At that time, a lot of white patches are developed in the oral cavity, because already, see, again I would stress that as oral pathologists or as dentists, we deal with all types of tissue. Oral cavity is a miniature body. We have bone, we have muscles, so lots of diseases that are seen in the entire body are seen in a small space of oral cavity. So what happens is that when these patients undergo immunosuppression, they develop white patches in the oral cavity that resemble lichen planus. So if the attendant clinician doesn't know that that person has a recent transplant, the diagnosis could go wrong. So these patients have to be informed that they are more susceptible to certain diseases or certain fungal infections in the oral cavity also. So under this white patches that are seen is called as a graft versus host. Basically white patches that are seen in the, so it's a graft that is there in the patient actually, that leads to certain oral manifestations. Am I
Okay.
clear?
Yeah,
So
yes, ma'am. Yes, ma'am. So, ma'am, in the next slide, you talked about E-cadherin molecule.
hmm,
So, ma'am, as far as I know on cancer, that cancer cells go epithelial to mesenchymal transition.
yes.
And in epithelial cells, the level of E-cadherin is more, whereas in mesenchymal cells, the level of N-cadherin is more. So, ma'am, if we go for biomarker as a N-cadherin, then would it be good, or taking biomarker as a E-cadherin, it would be more? What do you suggest on?
Here now, there's no, the problem here is that e-cadherin is being explored as a marker. The question is, see, what in very layman terms, what do we call as cancer, where a tissue which was not supposed to be there, it is there. Like suppose I had epithelial tissue, the epithelium is not supposed, epithelial cell is not supposed to be found in the connective tissue. So that is cancer basically, where normal tissue should not be, where normally the tissue should not be there, it is found there. So what has caused, what biomarker change has occurred to that epithelial tissue to shift to the connective tissue? So if you go at molecular level, this epithelial mesenchymal transition, so the epithelial cell has now developed the biotype or a phenotype where it is able to shift its position from the epithelium into the connective tissue or into the tissue that is below. So, if N-cadherin is expressed more, that means that phenotype of cell has more tendency to shift to connective tissue. So again, now there's a question there, but if this see, but I feel every cell by birth has a tendency to do what it is destined to do, be it cancer or be it normal cell. So that if even if it is expressing N-cadherin, it could be a transitional point where it has shifted to the connective tissue. But eventually, maybe E-cadherin will be expressed more because it has this tendency to connect to each other. Like if you ask me that every epithelial cell has this tendency to enhance lots of cytokeratin, and it has this tendency to stick to each other, like they're very sticky cells. So what happens is when this cancer cell developed a phenotype for change, maybe at that transition it was expressing N-cadherin, but when it now reached into the connective tissue, survived the entire body immune system surveillance, maybe it is expressing again E. So at what point which biomarker has to be used is the challenge now. See, if I'm testing that person when the transition is still about to happen, maybe he is just expressing E. But when that particular phenotype of cells are entering into the connective tissue, maybe expressing N. and when it is again growing in the connective tissue, it is again expressing E. So this is a very challenging process, and believe me, as oral pathologists, we understand all these molecular things, but we again, being the connect with the patient, we have a lot of aspects as a doctor also to perform. So and in India now, we are very much aware that newer techniques will help us. I mean, there's so much of development of genetics. Like previously, no, we never used to hear about people getting prenatal testing also for genetics. Now it has become routine, like, for all these markers, chromosomal aberrations and all that. So eventually, maybe next 10 years, we'll all be talking in more scientific or more molecular level terms.
Yes, ma'am. So you basically talked about that early diagnostics can really help a lot in this. So, ma'am, we are entering into the world of artificial intelligence, and you talked about omics as well. So, how we can use the artificial intelligence and omics as well, combining together to find some groundbreaking breaking research to develop some early diagnostic kits. Is it possible? Can you, ma'am, please
Yes, yes, yes.
shed some light on?
See, there are two different things. First thing is that the fear that artificial intelligence is going to take away the pathologist's job, that has to be taken out. And we have to embrace technology. Now, right now, what the research is going on, we are now in the stage where we are testing, or we are teaching the artificial intelligence to recognize cancer. Like a lot of work actually is going in Calcutta. I know people working in Chandigarh. I know people working in Ahmedabad, who are developing apps where the patient will take a self-examination photo, and through the AI, they're going to say whether he is going to, if he is positive for pre-cancer or cancer, or
Mm.
is he suffering from any lesion. So we have to start accepting that AI. Like, I think if you have used on Digi Yatra in the airports, we are now embracing it. It's going to be something like that, where you just have to click a photo of your problem, and just immediately, maybe it would be the AI or the doctor, they will be able to help you to reach or take secondary help or more professional help. So if we are dealing with huge country like India, where maybe the specialist doctor is not available, and the delay of treatment is occurring because of the lack of specialist doctor, maybe we can fasten early diagnosis. So a person who is there right now in Porbandar could immediately say, yes, this is how I have to go and consult a doctor in Ahmedabad. uh, Even if the access is not there at his place, maybe he could at least make an effort to come back and do it, rather than saying ki, "Arey, I'm fine." So yes, AI will be there, and lot of data analysis is going on, because huge amount of data is getting generated these days. Digitalization is occurring. So the lot of machine languaging, or the deep learning algorithms are being developed to for the machine to recognize cancer. So at two levels, work is going on at clinical level, where photographs or the AI is being trained to detect the subtle changes in the mucosa, whether it is red, whether it is white. So where you have to talk about the area of interest, that is ROI, and stage that this is how the problem is. The second level, that is going for the microscopic slides, where everything is getting under digitalization. See, as a pathologist, I am going to see a lot of patterns. I see a lot of changes occurring in the cell. So AI is being taught. So huge amount of data. See, like, what we understand is one single slide when scanned is going to be a very daunting task, even for a pathologist to go through every point. But if you have an simple algorithm where it is able to tell you, yes, this is the area where you need to scan more, so AI can help the pathologist to screen faster. So a lot of development is going on in detecting those small changes. See, AI will not be able to work as a human brain. Human brain has these connections that I can link a small change to cancer, but AI will say this change is present or not at right now. What is the situation that is going on? So AI can help the pathologist to say, yes, this is the area that you need to scan or spend more time. So there again, early diagnosis, early faster diagnosis. If I would take about a half an hour to go through and report my diagnosis, maybe AI could help me screen more patients in that half an hour, reducing my workload. So there's a lot of implications of artificial intelligence is time that we take it up.
Yes, ma'am. So, ma'am, I guess we could have interacted more and more, and I would have learned a lot, and our audience would have learned a lot. But we don't have a whole day, we have a limited time as well, and your time is also very precious. So, ma'am, we would be ending our event in a few minutes. The last question is, the next question is that what was it like to present the Dr. Abhay Chandak Memorial Oration Lecture, and how did it influence your outlook on research and teaching?
Yeah, here I would like to highlight that there's an Indian Association of Oral and Maxillofacial Pathology. So this oration lecture is given to young researchers. There was a screening committee which was there. I was asked to put up my CV there, and the question that was put up is that what work, significant work, have you done in the past 5 years or 3 years? So surprisingly, my work during the second phase or the second stage of COVID was highlighted. I have lots of publications. I have 2 or 3 PubMed index, like index publications. Like extensively, I have worked on research during COVID and mucormycosis during COVID time. That helped me get this oration lecture. So it is in recognition from my association that yes, you are going on the right direction or the path. And the topic that I gave during this oration lecture was again molecular profiling of odontogenic tumors. Now, you would ask me what is odontogenic tumors. I would break up the word. Odonto means teeth, and genic means any tumor that is occurring in the jaws. And in India, that is the bread and butter of oral pathology. So most of these tumors are diagnosed via the microscope, but most of these patients come late. So my personal interest was how to apply the omics again, how to apply the small subtle changes that are seen in the genetic level, why a particular lesion is shifting to tumor. So the entire oration lecture right now was there, that all was on profiling, genetic profiling of odontogenic tumors affecting the jaws. And it was an excellent experience. I had given it in AIMS Delhi. So it actually prompted us to work a lot on a particular lesion in oral cavity, that is odontogenic keratocyst. That is one more area of my interest. Certain papers are on in the pipeline where we are actually working with other researchers all over in India, where this odontogenic keratocyst occurs with certain particular syndromes. So we have patients where this lesion occurs, like, in 11-year-old, after a year, she comes with another lesion. So certain genes have been identified with the occurrence of this lesion. So is it common in India also? That is a question mark. So because all these diseases have regional prevalence, and if we are able to help these people who are genetically inclined to develop these diseases, not just oral cavity, these people have melanomas also in them, basal cell carcinomas also in them. So we may be able to help them actually. So a lot of precautions, a lot of diagnosis goes, a lot of things into genetic aspects have to be still, like, we're still in a very nascent stage to do develop genetic work, but yes, it has prompted me to get into it, and it helped me to network also.
Yes, ma'am. So, ma'am, lastly, what advice would you give to the younger generation of dentists and researchers who want to specialize in oral pathology and pursue a career in academic research?
um, See, as I said in my presentation also, uh, as good is your pathology, so that good is your practice. So the branch is an evergreen branch. Yes, we are going through ups and downs, but if we evolve and if we embrace new technology, that means, and we don't leave our basic dentistry also, oral pathology has a lot of scope. I would like to believe that it has a lot of scope. It would encourage a lot of people to take up oral pathology as their master's degree, and those who are already doing do group practices, encourage various clinicians to submit biopsies to you, so that we can use our degree to good, to better causes, better use, directly affecting the patient. Because most of the time what happens is Indians are not aware that every tissue that is removed from your mouth or the body has to be studied, has to be observed. So we have a lot of work, we just have to find the right way to find it.
Yeah. Yeah. So with this time, our time is ending, and it would be really great if we can have some offline session on oral pathology, because in oral pathology we would be dealing with the microbes and also, and there would be some hands-on workshop as well. Is it possible? I guess.
Yes, very much, very much. And
Yes.
it would be great. I mean, I would look forward to it actually.
Yeah, ma'am. We are also, because ma'am, everyone in our community is means they are from abroad, and the time zones is literally very different. Someone higher India is 10:30, so there they are 4:30. So it's very difficult to bring everyone together. Yeah, but in India we have many good audience and scientific audience who would love to attend such things. So, ma'am, with this, I'm really thankful to you for providing us some time from your busy schedule and providing us with great insights of knowledge on oral pathology and oral and dentist sciences. So, ma'am, yeah, with this, I'm really thankful to all the audience, and I would be posting the feedback link in our in the chat box, if you can, so that you can receive the e-certificate for this event. So please do fill up the feedback form posted in the chat box. So I'm really thankful again to you for joining us, and I'm also thankful to all the audience to join and attend the session very sincerely. So till then, think, share, and go. Thank you, ma'am.
Thank you so much for the opportunity. Yeah,
I hope you enjoyed interacting with us.
I did.
Yes, ma'am. So thank you really, ma'am.
Yeah, thank you.
Thank you, ma'am. So bye everyone, and please do share, subscribe, and do like our channel and videos, so that we will come up with more future and more engaging and insightful talks in the upcoming future. So I hope you enjoyed it, and please do fill up the feedback form posted in the chat. And then bye bye. See you and take care.